years ago.
I can see the See It advertising in the background.
Yes.
Oh, pretty cool. I might do it one day. I'm a bit tired today.
I uploaded a whole heap kind of months ago, and so I just kind of cycle through them.
Yeah,
Very good. I haven't got many. I should dig out some.
it's quintessentially Spanish, isn't it? I'm kind of looking at the background and seeing
Hang on.
like it's kind of on a hill and there's terraces and terracotta roofs. Huh?
Yeah.
White buildings.
Or is Portugal?
Portugal, it is in Portugal.
Yeah. So it's the Mediterranean.
Yeah.
I've never been.
Southern Europe.
Actually, I've never been to the Mediterranean, to be quite honest.
Ah, it's beautiful.
Oh, you have to go, Sally.
I've been to the Caribbean, but not the Mediterranean.
That is on my list.
Oh, I
Yeah.
quite liked it, but it was hurricane season, unfortunately.
Maybe not.
Just
Might-
before
might-
Katrina. It was like 2 weeks before Katrina.
Oof.
There was a conversation about Japan. So
Yes, I was
is-
trying to think. That's looking very.
that's Nara.
Ah,
Did you go to Nara?
yeah, all the deer.
Yeah. It's funny. I just posted a more obscure picture from Nara and said most of you will know it for the deer, but I
Yeah.
posted an obscure photo, so
Yeah,
without saying the name. So hopefully someone will figure out what it is.
it was a good day trip.
Yeah, indeed. Very good. So what do we know? I saw something this morning. There's a company in the US, and I think it's called Olive. And so Olive's a unicorn because it's worth $16 billion US. And apparently they advertise the fact that they've got automation and AI that will save hospitals lots of money. And so someone's done an expose on it. And I'll make sure I dig it out for the notes. But essentially, Olive tells a good story about how they'll save hospitals money, and never really does, in terms of efficiency, process efficiency, administrative efficiency, and things like that. So it was quite an interesting takedown, because particularly in the US, when you're talking about startups and things like that, from a technology perspective, it's very antisocial to start raining on somebody's parade of either wanting to raise capital or wanting to pretend that their startup is better than it actually is. So I was really surprised to read that, but I'll make sure I share the link to the article and a little bit of that buyer beware type thing around technology, where something like Olive, also like Theranos, maybe it wasn't as good as people thought it was going to be. So yeah, I thought that was quite an interesting article to start my day with this morning. Mary, have you seen anything in the news recently?
Yeah, I posted an interview on Yammer earlier this week about sleep trackers from the perspective of, there's an associate professor and clinical psychologist in the States who specialises in behavioural sleep medicine. And she talks about whether the data captured on these devices is useful from a research and medical perspective. Like, for example, there's opportunity to understand sleep at a population level, like the impact of daylight savings or different age groups and sexes. But she also touches on how mobile health trackers tend to be used often by the worried well, and people with sleep trackers often get caught up on the specific numbers, like, oh, I only got 7 hours sleep, and their watch told them that they didn't get enough good sleep or REM sleep, but a clinical sleep study will show that their deep sleep is good or whatever. Or they're making their sleep worse by lying in bed longer to get good numbers, which it's kind of the opposite of what you want for someone, like if you're an insomniac. But however, on the upside, it was also a good conversation opener with their GP about their sleep, which may be a catalyst to them being referred to a sleep study. And then the final bit was, another part of another study suggested that clinicians are often less keen on the devices than consumers. So there was one study using Fitbit Charge and the Sleep Life portal. I don't know much about it though. The patients were very engaged, but only one clinician out of the 49 actually logged into the portal to check up on the data. Surveys showed that sleep professionals showed they were wary of the data and sometimes found it frustrating because it took time out of their clinical catch up with their patient, because the patient wants to to show their data. So yeah, I mean,
Interesting.
though.
Yeah.
I
Two
had
direct connections in my head on that. So the first one is Auckland DHB has a sleep science lab, and they've got a pile of data. So they were busy trying to work through actual sleep science and can they do something with that. And then the other thing is, we might, after you, Sally, bring Chris into the conversation, because there's this interesting question about how you actually notify clinicians that something's either wrong or something isn't wrong. And the thought that a clinician might not check it is a bit risky, but I can also see why they might not bother to check it. So, Sally, what did you think of that?
Oh, I was kind of going to say the same as you a little bit, but I was also going to say it kind of depends on the data and it depends on the clinician, very much so. Because sadly, I did a eye pressure checking thing over a couple of weeks, and every 2 hours did it. And my and being the silly data person that I am, I actually graphed it and did all sorts of correlations and things like that on it because I could. And the specialist goes, why can't we have it presented like this? So, but that's a clinician to a clinician anyway. And it was looking at circadian rhythms and eye pressure. That was just a personal thing. Yeah.
Yeah. Well, you're probably firstly more educated than most of the patients that turn up.
True.
Do you know what I mean? Like, and so that kind of makes a difference in and of itself.
But from a clinician's perspective, I also agree with you, Mary, about the worried well.
yeah.
I mean, look at Starship. I used to do phone triage at Starship when some of the more accessible baby monitors were coming in and things like that, and parents were just too much data could be enough thing, and how do we pull out the right data?
Yeah.
Anyway, I'm ranting.
Very good. Chris, did you want to introduce yourself? Did you have any opinions on notifying clinicians about data and changes in data? I'm sure you do. And I was looking for a hook to get you to introduce yourself.
Okay. Hi everyone. Yeah, I'm Chris Paton. So I'm a clinical research senior lecturer at the University of Otago, and I've been setting up a new postgraduate digital health course. And I'm also a clinical researcher for the University of Oxford, kind of remotely, and I work in Kenya and Vietnam on digital health projects. So most of my research is about digital health in low resource settings, but obviously we teach quite a lot about high resource settings as well on the course. So yeah, I think there is a problem with kind of assuming that doctors are going to be monitoring patients remotely. Just, if you give the technology to the patients, then all the clinicians will just start using it for monitoring. And we actually discussed this. I teach on a course in Oxford, and I was teaching last night, and we were discussing this issue. So there's been a review which I'll send, which one of my colleagues in Oxford did, of several telehealth projects, and the kind of point that they made was that you need to design them as a complete service with all the clinicians who are going to be involved and the people who are going to be involved from the beginning. So one of their case studies was actually the first project that I got involved with in Oxford, which was a heart failure monitoring study, where we gave elderly people with heart failure stick-on patches. I don't know if you've come across Proteus Digital Health. They have this kind of, they've designed it really to track medication adherence with these dissolvable sensor pills, but it also tracks whether your position and your activity and things. Anyway, we stuck these on these poor elderly people and monitored them, and they used a tablet computer as well to enter their kind of weight, and had Bluetooth scales and things. And it was very technology centered, really. And that was one of their case studies of kind of how not to do things, really. But there are several other studies about, that went well, and the ones that went well were really thinking about the whole service, thinking about who's going to be, whose day job is it going to be monitoring these things, and what are they going to do if something goes wrong, and thinking it all through. So it's very easy just to put technology in and think everyone is just going to rally around and support it.
Yeah, totally. Welcome, Chris. Normally we have people continue to join or join during the session, but this week's a little bit quiet so far. Eileen, did you have any thoughts? Because this kind of connects to your home sensor work that you're doing as well.
Yeah, it's an interesting concept around, when you give people tools, do those tools become a bit obsessive in terms of constantly need them? Like, there's a bit of psychology, I think, that sits in behind, tools, wearables, this whole kind of new venture that we're just tipping into. There's a lot on the market. What's good, what's not good? Is it useful to always know what's going on, and be connected? What points do you want to disconnect? Yeah, I think there'll be some. I think there'll be some interesting research that comes out in future years. I was talking to Mary earlier about this. That there seems to be a wave whenever anything new gets introduced into society, particularly in technology. There's an element that it goes too far, and then it's kind of like, how do you peel that back in a way that, makes it more normalized? And I was thinking about, when I was reading that article, the fact that we're seeing a lot of like VR type therapies that are almost replacing pain management with pharmaceuticals. So there was a pill to fix everything for a period of time. That's what it felt like. Just give people a pill and send them on their way. Whereas now it's kind of swung back the other way, where there's actually new digital tools that are replacing some of that need for, pill, different pain management, or, chemically induced, effects on the brain, where actually you can train your brain to respond in a different way. So for me, that's quite an interesting area. It's like, how do we use tools for the greater good, and at what point does it become a good place to be utilizing them more, and not actually becoming a bad place for them to be?
To me, that's kind of an extension of the theory that the technology is neither good nor bad. It's kind of how we choose to use it. And so then you think about social media in that context, and I'm assuming that's where you're going in terms of, training your neurotransmitters to like or dislike, the use of certain technology, or, to gain pleasure from, likes on Facebook and things like that. And obviously that's more and less conscious in terms of how you do that. So
yes,
yeah, Facebook's got a lot to answer for, or Meta, as we call them now. Cambrian, I'm sure you have an opinion in this space as well.
Totally. No, I was just listening in, and I've been testing some monitoring apps, like digital apps. And the one that I had recently was one called Tori, which you put your finger over the camera flashlight on the back of your phone, and it measures your heart rate variability and different attributes through that. And it gives you like this insane feedback, like 10 different health readings, and one of them's stress, so it tells you how stressed you are. And I was thinking just before, it's like, how functional is that info? That it's like, is that good to know? What do you do in response to that? Like, but there was another curious one that I wanted to talk about. It was this personalized low alcoholic scent cloud that measures and assesses your mood and releases like counter emotional distress smells into your personalized scent bubble. I'll send you the link in the chat,
please
because
do.
it's like it was the most innovative piece of tech that I think I've seen in a while.
Yeah. Do they advertise it on TV in the mornings when they do that yellow submarine thing that catches you all the fish, and never doesn't catch any fish, and along with the guy that sells the ladders on the morning on TV? Is that where?
Haven't been on TV early in the morning. I'm waiting for it to turn up in my algorithm on Instagram or something like that.
Yeah, or on YouTube.
Yeah.
The amount of time I end up going down YouTube holes in terms of, you start watching a video and suddenly YouTube decides that you want to watch all of the videos about that one thing, rather than you want to learn about that thing a little bit and then go and learn about something else. Yeah. Self-reinforcing patterns.
Dangerous.
Yeah.
Dare I mention TikTok?
Yeah, indeed. Something else obviously that's happened in the last couple of weeks that maybe we should have a bit of a chat about is HiNZ. So I'm guessing a bunch of you went to HiNZ. were there any talks that you saw at HiNZ that you kind of went, oh, that was not what I expected, or in terms of learning something exciting? Matthias, I know you went to lots of talks last week at HiNZ. Which talk did you enjoy the most?
I did. I really enjoyed the co-design one, mainly because it's not something that I normally think much about. But you know, everything that they were saying, I really enjoyed. Obviously, I think it would have been quite interesting to sort of expand out who was on the panel of speakers to people with whom the co-design had occurred.
Sure.
It's not that I didn't believe what they were saying. It's just that it would have added that extra. I guess it would have made the conversation more dynamic, you know, because they can make lots of promises and say they're doing all these cool things. Yeah, it was really good. It was quite overwhelming. I felt at like the end of it, my brain was a bit fried. But it's only the second online conference I've been to, and it was run quite well. I don't know about you guys, but I feel like a live chat feature would have been really useful. I had that on the one that I went to previously, and there was loads of really cool like kōrero in the live chat as
well.
Sort of the panel was happening. So yeah.
My favorite one was Matthias too. I'm going to run. But yeah, I thought the co-design was cool. I'm, just so you know, talking on a telehealth panel on accessibility next week, I think, or somewhere soon anyway.
Is that the telehealth resource group, the National Telehealth Resource Group?
Yeah. They've put a panel of people together, and I thought I would go and talk about design science, because all the other people are clients, and I thought, well, I'm a client and a researcher, why can't I talk about both?
Yeah, good plan. Good plan.
Anyway,
like
I'll talk to you later.
Very good. Michael, did you go along to HiNZ last week?
No, I didn't, unfortunately. Yeah, sounds like would have been keen to see that co-design. Is that something they're going to post up after the event?
I think all of the videos go up on their website, so you can peruse them at your leisure. That was kind of the hardest thing, I think, for me, was there were so many videos because they were doing 3 parallel conversations or 4 parallel conversations for sessions, and each of those people pretty much had done a presentation. So the amount of content that got generated for that conference was just huge. And so I ended up chatting about real-time data and ended up chatting about transformation in the health system, and I got some questions asked by people that I work with. And I'm not sure if that was, if I got easy questions or I got hard questions on purpose or quite what was going on. But it was interesting because if you look behind the curtain, all of the speaking was happening on Zoom, and then they were running a screen grab of the Zoom conversation, which was then being broadcast out to everybody. So that was kind of how it worked with the tech behind the scenes. I think some of the facilitators did better jobs than others. It is a bit hard if you don't know the people to have a really constructive conversation, because you're looking for someone to pick up on something you've said and to be able to hand it on to make it more of a conversation than just a monologue about answering well-intended but pretty narrow kind of questions. So that was a bit frustrating for me, and as always I end up overbooked and all of these things. So when we've had the in-person HiNZ, I'm always ending up standing because we would have a conference booth, so a Ministry of Health conference booth. I end up standing at the conference booth talking to people rather than going to the sessions. So it was quite nice that I could actually go to the sessions, but at the same time I had appointments all during the day and as well anyway, so that was slightly frustrating at the same time. Very good. So yeah, Eileen, did you have a favourite presentation?
Not really a favourite. I'm still making my way through quite a few of them. Rachel Guthrie from TAS did a really good presentation on framework for equity. It's quite interesting, the approach. The presentation really talks about the approach of building the framework and then how you go out and commission for that from different providers. But it was just quite a pragmatic way of describing what digital equity looked like, and they framed it in the way of enablement. So how do you enable people to engage through digital channels? And they broke it down into different stages. So what is like the first stage is like, well, you need a device, and then you need to be able to connect to your device, and then you need to be able to be comfortable and be motivated to use the device to engage with that. And it was just focused on telehealth services, and this was really a result of the COVID March lockdown 2020, and all the GPs suddenly having to shift a huge lot of their services to virtual appointments. So for me, it was just a really nice example of how you can articulate a way of working that makes it easy for other people to kind of look at that and go, oh, for my service, I could do that if I just, framed it like this. So I'm quite keen to reach out to her and get her to come and talk along to the cross-government group looking at digital inclusion, because I think some of those are struggling a little bit at what that looks like for education or, DIA, because I think they're trying to fix the whole problem rather than actually just looking at a single service line and go, what would it look like for that service line? And then how do you build up the building blocks? Because, once you've done the first part, which is getting someone connected, that kind of like lowers the bar for everyone else behind you that's trying to deliver a digital service. So then it just becomes, what is the unique to my part? Yeah, so worth watching if you want to learn more about equity, digital equity, and how to build a framework.
I'm wondering, Matthias, if you got to, and this might be interesting to you, Michael. There was a guy called Isaac Tranter Entwistle, who appears to be either a registrar or a general surgeon in Canterbury, who was looking at collecting video of surgical procedures, or is collecting video of surgical procedures.
Yeah,
and then,
I did see that.
I watched it, and so the interesting thing about machine vision is the tagging. It sounds like, so because he's a PhD student as well as a surgeon, it appears they're getting his time relatively cheap to go through and tag all of the surgical videos. But just kind of a really interesting question about the types of things that benefit. So it's not obviously just the surgical outcome for the patient that might benefit because you get a better technique. It's actually the surgeon. So it's a training tool as well as a patient outcomes tool. And I was kind of like, oh, that's quite a good way of thinking about it. So, two different, very different benefits from the same kind of process. But yeah, I watched that and I was like, oh my God, imagine having to tag all of that video. That would have just been terrible. And it's, one of those things that you kind of go, I wish there was an auto tagger of some description, which maybe is what that captcha thing is on websites. But
I don't think you'd be able to make a captcha for surgeons,
A captcha for everyone else that's not a surgeon, yeah.
Google or Facebook must have something.
Yeah, maybe.
Set up
but,
for that.
Yeah.
What is it? Was it a certain type of procedure, like a endoscopic?
It was a endoscopic cholecystectomy, I think, and
he was a gastric surgeon, right?
Yeah, general surgeon. Yeah. So cholecystectomy, I think he was doing in laparotomies maybe as well, but endoscopic ones. So might be a useful person to have a chat to, Michael, because it seemed like they were reasonably far along in terms of the data gathering, and kind of an interesting question about, not only, I imagine, will you get kind of some really interesting questions about the technique, but in the questions about the technique, you start to then go, well, what are the instruments, and are the instruments doing what you want them to do? And if you were to change the instruments, does that make the technique better? And so there's probably quite an interesting loop of, continuous quality improvement almost in that, as much as kind of, the novelty of building a machine vision algorithm in a surgical context. Because it seemed to me in the presentation, Matthias, no one's really done that ever before. Like he couldn't.
Yeah, well, I mean, if there wasn't a labeled data set, either what they have done is hidden behind some proprietary tech, or no one's done it before at all.
Yeah, there was a connection to a vendor, wasn't there?
I can't quite remember. I think the hard thing about the HiNZ conference is like all of the sessions seem to blend together for me, like because you don't have someone speaking up on a stage or whatever, But
The
no, it's
dangers
good.
of a online conference, maybe.
Yeah, it was. I will just comment quickly on the machine learning AI session. It's funny that that was actually just like a precision-driven health session. Like it was literally just Orion Health and precision-driven health, which I thought was quite funny.
Yeah.
I mean, it was
although
good. It was good.
I mean, they're probably doing the predominant amount of machine learning in association with the health system in this country.
Yeah.
And so I think it's a little, it was interesting. I asked a couple of questions specifically around one of them around social license, I think. But yeah, no, they are doing quite a bit of work in NLP and coding, very little in the machine vision space. So there is some stuff out of Dynas Hughes Group in Auckland Uni that's doing the machine vision work. But you can imagine machine vision being quite a handy thing in the health system, because at the moment it relies, our information relies on someone seeing something, interpreting it, writing it down, and then us converting the free text that they've written into something that's then codifiable. So you're kind of quite removed from what actually happened. And yes, you've got the benefit of kind of the clinical insight and the clinical overlay, what gets recorded, but it's not video. Do you know what I mean? So slightly different.
Yeah.
Yeah, for me, like that's a really useful tool, like you say, in the education. I was thinking we looked a while ago at something like this in neonatal resuscs that, you try and do simulation, which is infrequent and not very often, but having like real-time events like that you can view and then get an idea, using some of the AI maybe for tagging about what was right or wrong, just to feedback. Those are those learning opportunities all the time that you can have that, especially on those sort of events, that useful tools.
Yeah, it's funny because it's the tagging in itself is probably a useful learning episode to go, oh, I see that I did this thing. Oh, why did I do this thing? Do you know what I mean? Like, as much as then you've created a data set of video, which you then create a set of algorithms off the back of. So yeah, the exercise of the tagging is possibly as good as the use of the algorithm afterwards. Very interesting. Very interesting.
I've got a business idea, which is getting medical students to tag surgical videos as they're training to be surgeons. Free labor.
Free labor. I'm not sure it would necessarily be free. Although maybe you could force it to be free somehow. I don't know. But
otherwise, you'd get a captcha pop up and it'd say label which organ this is, rather than buses and planes.
Buses and bicycles and cars and traffic lights. Do you reckon?
So Chris and I were on the same panel discussion for the last workforce session. That was quite interesting.
What was that? What was the focus of that conversation?
It kind of went in directions I didn't anticipate. So I think there was a question around micro credentialing. That's a tricky word to say, which I wasn't anticipating at all. A good conversation though. I think there's the way that we learn stuff, and the way that we gain certification or accreditation. I think there's a space in there that's kind of like, what's your formal training that you do at university, and then what after that, and then what do you do in terms of additional learning that is a more formal aspect, and then what are the things that you just kind of like you want to do little bits of, but not necessarily take a whole paper, and then how does that like chunk itself up? Yeah, it's an interesting space. I don't know if Chris has a thought on the conversation.
Yeah, I thought it was really interesting. So quite a lot of it was kind of outside of what I do, really. So I'm not involved in kind of health professional training at all, really. So I think I was just on the workforce panel because I run this postgraduate diploma in digital health. So I'm interested in the digital health kind of workforce. Yeah. But I do quite like the idea of micro-credentialing, because we've got this smartphone training app that we use for training healthcare workers in Kenya. And we've been doing kind of or kind of attempting to do certification through it, so that so it's on. I think you mentioned neonatal resuscitation. It's actually on neonatal resuscitation, and the idea really is that the nursing college can give accreditation to people who've been through the training and scored highly. And our idea really was that part of the problem with neonatal resuscitation, as Mike was just saying, is that you forget, like if you do the training once and then you have a resuscitation that you have to do in 2 years' time, you probably will have forgotten it. So we put in this idea that you have to keep redoing it, and we did it based on this kind of 100-year-old theory of spaced repetition, where you do it kind of do it once, then do it in a couple of days, and then do it in a few weeks, and then do it in a couple of months, and just using data. We had a PhD student doing some kind of AI stuff on it that tries to work out, you know, when you should be redoing your training in order to keep it up. And so that was quite interesting. So I kind of like the idea of that for health professionals, like just make, because what you got to think through, what do you want them to actually be able to do, as opposed to, because part of the problem is, and kind of I had this when I was doing clinical work, is that you start a job and you have to do all the mandatory training.
Yeah.
And then by the time you actually need to use what you've learned, you've probably forgotten it. And also that process of doing the mandatory training is so kind of onerous that people don't pay attention anyway. And they use these terrible kind of compliance-y learning systems that you just kind of click
that
through.
Everyone wants to shortcut. Yeah.
So I think there's a lot you could do with micro credentialing to make it more based on keeping the knowledge and putting it into practice and that kind of thing using technology.
Yeah. So conversation came up today a little bit around some of the how do you. So as you all know, we've done recently work on the My Vaccine Pass, and the My Vaccine Pass is kind of a credential, so it's a declaration or a assertion that you're fully vaccinated, or you're in the eyes of the government, and that the method of creating the QR code, which is digitally signed, means that when you carry it around, say Chris, you went from working in one hospital to another hospital, one provider to another provider, you end up being able to present the QR code, and because it's been signed, you don't have to do the training again, because everyone can see that you've already done it, and they can verify that you've done it. So that's something that we're really interested in, because the first thing on the list is, and Cambrian, you possibly see this as a big barrier in kind of the community mental health space, is police checks. So police checks, the number of police checks that you have to do, and the fact that it's not something you can carry around and take along to the next place, and the fact that it costs money, all mean that it's kind of, for a lot of providers, it's a very onerous requirement. But of course, it's kind of a good safeguarding tool, a big thing in the UK. But that if you could get it printed out with a QR code that's verifiable, say with your name and details in it, and when it was issued, if you had that as a QR code, and you could, or even print it on a piece of paper, take that along to your next job, and your next job, suddenly you've got something which has that ongoing, or enduring kind of value, as long as you don't lose it, obviously, if it becomes the question. So, but it's a little bit more than trying to take a photocopy of your degree certificate or something, like, really, is that actually your degree certificate? And so, I know universities do a lot of kind of background checking of people's qualifications, and there's whole computer systems built around all of this. You kind of go, well, maybe the person, if they carried it around as a QR code, would be maybe a better option. So
can I
definitely
set up
something.
A wallet of these things, like it's just a wallet of verified documents?
Yeah, well, yeah. So that's that. There's a really interesting question about that. So if you think about the attributes that make you you, so turn your driver's license into one of those things, turn your passport into one of those things, turn a community services card into one of those things. Now the tricky thing becomes when you try and add them together. So how do you differentially add bits together that means you're only giving out the information you need to give out at the time? But yeah, no, totally. With at least with a wallet of things that people can say, yes, that's the original version. So yeah.
Why would you need to add them together?
Well, so if you think about there's a term called selective disclosure. So selective disclosure is really a process by which it maintains your privacy as a user. So I should only ever have to disclose the information I need to disclose in order to prove the point I need to prove, not all of it. And so you might have an attribute on your driver's license, which is your eye color, an attribute on your passport, which is your date of birth, or maybe that you need corrective lenses, and both of those attributes together, along with your name and date of birth, mean that you can claim some sort of subsidy for getting new glasses or something. I don't know. So, but you don't have to provide all of the information that's on your passport, like the places you've been and all of those sorts of things, in order to make that claim or to get that thing. So, so it's something that we tried to build into the My Vaccine Pass. So if you look at My Vaccine Pass, pretty much it's only got first name, last name, date of birth, and are you considered to be vaccinated? Because if you look at what we've done for the international certificate, and this is an interesting contrasting problem we're just about to hit. If you look at the international certificates we built, it's a health record. So it's a health record. What did you get dosed with? When did you get dosed? I think it might have an identifier for who dosed you, and what did they dose you with. And so that's a whole lot of information that the bar on Courtney Place doesn't actually need. All they need to know is, are you vaccinated? Not who did it, or did you get it done at a certain place? So I think in that context, it's there's lots of potential in it, but I think it's quite nascent. So, 2 years ago, people didn't even know what QR codes were in New Zealand. Knew what barcodes were, but QR codes were a foreign concept.
It's just...
Oh, sorry.
No, you go, Michael.
Could you extend that into sort of like, if you've got type 1 diabetes, sort of like the medical alert? So that you can
100%.
integrate, that, so St. John's, whenever they scan it, they only access that part of the QR code with those health things, like you're an asthmatic or you've got, sort of a little bit outside of that vaccine one.
Totally. And if you at the moment, if you go into My COVID Record and you click on your NHI number, we've turned that into a QR code as well. So, if a hospital's got a scanner that can scan a QR code and you've logged in, you can confirm that that's your NHI number. I mean, it's, the number of people that might do that is low, but at the same time, if it helps 10% of the population for the cost of what we've done is really low. So it might have some value, and it might grow over time, because now that we've done it, we've shown people that it can be done, and other people might want to do it.
And that QR code's unique to you in terms of the data that's held on your health account. Is that correct?
So basically the data it holds is your NHI number. So
No, I was going to say, because with passports, I mean, all a passport essentially does is confirm your citizenship to a country that allows you to travel and enter into another country with certain visa conditions based on your citizenship. So it might even change the whole concept of what a passport is or isn't, if all you had in your digital wallet was confirmation of your citizenship status to a particular country. It's interesting.
I would love that. If it was geographically located and it could tell you how many days you're allowed to stay in a country after you'd entered it, that would just be wicked rather than having to guess.
Yeah. Well, I think the tricky thing will be, so at the moment, the key problem everyone pointed out with the My Vaccine Pass is that it doesn't have a photo on it, and so obviously it becomes a bearer certificate at that point. So it's got your name and your last name, but you need something else to corroborate the details that are in the certificate. So I could carry Matthias's as long as the people I was showing it to didn't realize my name wasn't Matthias.
And you were 22.
Well,
sorry, you're a bit older than I am, Matthias. Really?
Hey, I'll take it as a compliment.
Yeah, there you go. So there's a couple of things you can do. So you can encrypt. You can put there's some technology called stenography, which has been around for a long time. So you can use some of the attributes from a photo and compress that into the QR code. You can also bind it to the secret encrypted part of your phone, the bit that does your face recognition or your thumb recognition. And so if you take it off the phone, you've taken it away from that that encryption key, and so it doesn't work. So there's a couple of things you can do. Obviously, you can give your phone to somebody else, but yeah, it's definitely something that's coming, and something that there's legislation coming to the House very, very soon that will enable this as a something that DIA is calling a trust framework. So it's all of those things you can add together if you've got standards and accreditation to create a digital identity. So it's a very different model to what they have previously promulgated with
RealMe.
With RealMe, which was a centralized, you have to come to us and do our process for you to be you. Yeah.
As long as you have a New Zealand passport.
Yeah. And haven't lost the phone with the second factor on it. Yeah.
We're talking about wayfinding. I had a discussion with Justin yesterday about wayfinding, and
yeah,
be cool to use that sense that, you know, if you've got your NHI on there, somebody could go into a health area, you know, log in and say, then you would get tailored instructions around, you know, looks like your appointment is in pediatric outpatients. Cool. Yeah, because that's, you know, part of the stress of that. But the trouble is, like, you know, you could send out a letter, but if there's already something digital, you know, identifying who you are through that. You could then drive that whole tailored. How do you find your way with as least effort as possible to your
that
appointment.
would be useful for, you know, colleges and universities as well, you know, particularly for those, you know, first year students. There's places to navigate to different blocks and classrooms.
So that's a really interesting thing, because when we set up COVID Tracer, we were talking to Waikato University about QR codes representing locations, and they decided to create a QR code for every room in their facilities. A little bit as a bit of an experiment, and I should probably go back and follow up with them, because if you use the QR code to identify places, which is kind of what we were doing with COVID Tracer, you know, you could imagine the university building an application which was scan this QR code and tell us that the projector in that room isn't working. And so in doing that, the person doesn't need to know the name of the room or the location of the room. It's identified in an easy way for that person to say this is the room. And so it saves a whole lot of, you know, one of those classic problems, Michael, that you see in a hospital where you know there's definitely a pump in this ward, but where the hell is that pump? You know, because you need to do some maintenance on it, or, you know, you need to upgrade the software or something. So I think there's definitely, and that's something we're looking at the moment, is with the QR code system that we've built for COVID Tracer, given it represents business locations, what else could we be using it for? So one of the ideas we've got is you could combine what I was talking about before, which was verifying documents, with the location QR code, and then print it on a food safety certificate, so that someone couldn't make a fake food safety certificate for their shop, or when the food safety inspector turned up, they could scan the QR code to start filling out the inspection of that premises. You do it for fire safety in a kind of a similar way. So when you turn up, that means, you know, the fire safety inspector actually went to the place because they had to go there to scan the code, and then you're saving the effort of having to enter in, I'm at, 133 Molesworth Street, and typing that into your tablet or your phone. So kind of making the process more efficient and more secure was something that we've built for a completely different reason. So
is it possible it could just sort of migrate into just a national health portal? Yeah, 100%.
So today there are a bunch of workshops for HEDA, which is the program around joining up computer systems in the health system, and the workshops today are around certification. So around that question of, if we have these services, like we have a system that creates these verifiable credentials, which we do, on what basis would we give you access? So in order to use that system, and I mean kind of programmatic access, and that might also be access to data. So if you think about the App Store and the iPhone, something that we're really interested in is, we would love to make access to health information much easier so that people can build applications, but you've got that trade-off between making it available and keeping it trusted and secure. And so what is the right process for opening that up and connecting the data up? because the last thing you want is us building all of those connections or maintaining all of those connections.
Could I ask a data question?
Yeah, of course.
Based on last week's conversation, in the mental health space, there's a lot of conversation around safety and efficacy of new apps, and especially compared to this mental health space and the clinical side versus the wellness space. And some innovators are like, well, why would I bother being in this mental health space when I could just participate in the wellness area and be free of all the sort of stigma and stuff? But I've got a couple of innovators that are really looking at the retention data from government-funded apps like Groove or things like that. And I'm wondering whether I have had a quick chat with Ben about this, but whether that data is accessible, like whether those people that are funded are required to provide that data, and whether something as simple as like retention over a 60-day period, that kind of data would be too personal to have access to.
Yeah, so that's a really big package of questions. Just in the sense that I think the answer is, if they're creating health records, and health records might be defined as a person seeking professional help for their healthcare. I'm a bit uncertain about how you might define that. Then under the Health Information Privacy Code, the information has a determined storage or retention period. So, and then publicly funded healthcare then also has a Public Records Act requirement, which I think is 10 years minimum. So, but then retention and storage is different to access, of course. So just because it's being stored doesn't mean to say that everybody has access to it. And so this is a little bit of the problem that we're trying to solve. So we've got lots of systems where we know there's data, but just because there's data doesn't mean to say you can get hold of it for various reasons. So, you know, it might cost a company to build an API so you can get their data out. It might be that they feel that there's value in their data that gives them the ability to make a better computer system, you know, like the satisfaction of people for how quickly they can fill things out or something, I don't know. There's then also a bit of confusion, I think, in the market where people think clinical information or the information about the person is the business's data as well. And while the legislation isn't 100% clear, as a consumer, the Health Information Privacy Code makes it very clear that you are allowed access to your own data. And so in the fact that you're allowed access to your own data, it'd be really interesting in the context of those apps, how they make that happen. Because presumably the best option for them, if lots of people ask for it, is to make it an automated solution. But if no one asks for it, just have a manual kind of kludgy, email-y, downloady thing. Yeah.
It'd be great to use like something like Groove as an example and just be like, to know how users are using that app over time, because it's really just for other innovators to check how they sort of benchmark. And I'd love to drive it in the sort of private sector as well, as like a bit more sharing around data for collective good. But I
think this is the conversation we had last time, and possibly something that Chris is quite interested in, which is that question of there are some really interesting questions around customer experience, and user interface design in the health system, which we've never really created a lot of data around, or a lot of standards, or a lot of best practice around. So in that, you know, we're learning all the time, and you know, from our end, we talked last time about whether we would create a repository for the stuff we're learning, and you know, the conversation I've had internally is, yeah, let's do that. So you know, it's definitely on the cards, but it's kind of there's a little bit of sometimes we don't know what the questions are we want to ask as well until you want to ask them. But one of the things we did do was publish early on, and I've found a user for it today, the different types of phones that people in New Zealand use. So COVID Tracer, so Customs is really interested now, so they're running the travel declaration system, and the travel declaration system is mainly being filled out on iOS and Android, and so they're busy doing accessibility stuff. And I said to them, okay, well, you should be targeting your accessibility in the highest used phone types, so that you can then say our travel declaration app has been tested against these to be accessible, but you need to then know which phones to test it against. And so there wasn't actually a public source of the most commonly used phones in the country. So we published that as part of our work because it's not a competitive secret for us. And given it was such a, My COVID Record, such a big, highly used app, not My COVID Record, COVID Tracer is such a highly used app, we could be, you could reasonably assume it was a representative sample, having 3 million-ish users. So from that, there's some really interesting things that we can do, and probably depending on the questions you ask, we can actually get some reasonable answers, like things like how many level 2 My Health accounts are there. So we've got lots, millions now. How many have upgraded them to level 3? How many of them used RealMe to log in? What is the distribution of accounts across ethnicity, age group, demographics? So we can tell all that because the level 2 accounts are all associated with NHI numbers. And so we can start to look at what is digital access and equity at an extremely granular level. And then we can see, dumb UI things like how long does it take someone to log in? Like how long does our onboarding process take? When do people fall out of our onboarding process? So you can start to see there's really granular things we can do and really interesting kind of outcome-y type things. And you can, I would like to say, Ministry of Health or Interim Health NZ doesn't have a commercial motive in any of that stuff. So you can kind of trust what it is we publish. I think the tricky thing for someone like Groove is, you might be giving up kind of commercial benefits or commercial advantage by broadcasting that on the internet. Some businesses use that as that's what their commercial advantage is broadcasting it. But yeah, it's an interesting question.
If I was to frame up those questions, where do you think I would sort of direct them to?
So interestingly enough, I'm having some conversations with the mental health group at the moment. It's about slightly different stuff, as I mentioned last time.
Nice.
But I'll if you frame up the questions and send them through, I'm happy to forward them on to them.
Sweet.
They may be quite they may be hard to answer from the mental health group's perspective. So it may be that they just say, look, we don't know, what do you think, John? Because they don't retain technical expertise in kind of data or in digital services. So thoughts, Eileen?
Yeah, no, I was just wondering, I know Health Navigator have done a lot in terms of the clinical assessment-y type things of the apps that they look at, but I'm wondering if they've actually done any research in this space as well.
Yeah, I should send them a message too. It's just knowing who to contact in what area with those interests.
So the person at Health Navigator to probably engage through is Janine Bycroft.
Yeah.
So she's the clinical lead. She's a GP.
Okay. Super. Thank you very much for the help. It's fantastic.
No, it's the whole purpose of hosting these conversations every 2 weeks is to try and make it as open as possible. And if people have questions or need to be connected on things or want to talk about what's happening, we've got a time and a space to do it. So it's not that everybody has to come along. And in fact, I need to get back to posting these on the internet, which I promise I'll do after this one. So that people that can't come along can, listen in double speed on YouTube, which is what I do to lots of things. Eileen.
Question, have we, in terms of our Yammer page and the health forum, has there been any decision yet about us moving or staying or collaborating more closely?
Yep, there has. So Mary sent a contract through to Nathan, that's his name. I'm tired. Sent a contract through to Nathan last Friday. I haven't heard back from him, Mary. Have you heard back from him? Okay. I might have to give him a call. So you're probably familiar with eHealth Forum, which has got the Kiln on it and HiNZ forums on it. So we'll look to create our own forum on there and move all of our Yammer history and all of the people on Yammer over to that. So it'll give us, we've been thinking about doing it for a while, but I think our Yammer site works less as a forum to talk about things and more of a rolling social media kind of posting of things that might be interesting to people. So slightly different use case. So Nathan has to do a bit of work to change part of the site to accommodate that slightly different use case. Chris, you posted something there. What was that about the NHS?
Oh, it's just one of the service standards for NHS kind of funded apps, which just says that about making your performance information public and, you know, keeping your kind of performance data and that kind of thing. So I think it's something when you kind of the public are paying for, there should be kind of open data on how well it's performing.
Yeah. So is that clinical outcomes?
It depends.
Is that
So this
patient experience? So you can see where I'm kind of going here in terms of what is performance. Do you see what I mean? Is that profitability?
Yeah. So the basic thing is kind of like Google Analytics and things like that.
Oh yeah.
But then it does get, depending on what kind of app it is, there's a kind of evidence framework that says what kind of data you need, depending on whether it's just kind of the kind of lowest one is like infrastructure, like electronic health records or something like that, and then it's kind of information, and then it's anything that's kind of involved in clinical decision making and things like that. And for the different tiers, you have different levels of kind of evidence and reporting that you need.
Nice.
Cool.
I'd be really curious to look at that, and I think, yeah, it's the data that our innovators are curious about, is going beyond these sort of vanity metrics, like just user numbers to, like, that's why the retention data is so important to them, is like if they're not using it.
So you mean, so when you say retention data, so here's a completely, I got that completely backwards.
Yeah.
So I thought you were talking about data retention. So how long do you keep the data for that is in your system?
Right.
When you're saying retention data, as soon as you said
like,
vanity metrics, I figured out what you meant. So retention data is how many users that have downloaded your app continue to use it after 90 days.
Yeah, totally.
Yeah. Isn't that funny? So retention data, really interesting. We've got reasonable retention data on COVID Tracer.
Yeah.
So we can probably share that with you to give you a sense of that. But obviously it's quite a different use case. But it is also a habit forming use case.
Yeah.
So we could share with you, and I'm wondering if this might be a useful time period before it got compulsory to scan in places.
Okay. Yeah.
Because we definitely got analytics on when there were outbreaks for COVID and how the scanning eroded over time.
Yeah.
But I think, but it's all anonymous usage statistics because we didn't collect any of that data, but in terms of who was using it on purpose. But I think we've got anonymous usage statistics, so I'll send an email and see if we can figure out what retention statistics we have on that.
That'd be wicked. Do you have my email address?
I am sure Ben does, so I'll be able to pick it out. Send Maren an email, so she's our person that looks after COVID Tracer.
Very cool.
Yeah, isn't that funny? I just assumed you were saying it the opposite way round because I don't know.
Yeah,
why.
it's
saying it the other way
around. Misleading term as well, and like I don't know, used in the wrong way, perhaps.
Yeah. It's user retention, isn't it? Not.
Yeah.
So
data retention.
Yeah. Funny.
We got there. We
did.
We all went down the same path there.
Yeah, so I think definitely some of Chris's links would give you a really useful, and some of the stuff that mental health has done is based on this. But I don't think their framework has actually got usage statistics in it as a requirement.
Okay. Yeah.
I think it's more focused on, and I'm sure we are, which is a useful thing for me to take away. We're much more focused on the how do we get an agreement in place so that we can trust you to use the data or provide us data, not are you doing a good job of it? Which I think is kind of where you've got to, Cambrian. That's what Chris is kind of pointing out. So yeah, that's quite useful. Mark's joining in the last minute. Did you have something urgent to tell us, Mark, given you're joining in the last minute? Maybe he's joined accidentally. A butt dial. No? You joined on purpose, but at the last minute, Mark.
Me, no. No. I've got home especially for this one. So, oh, sorry, it's the wrong meeting. That's
You're
right.
wanting to join the header one next, are you?
Yeah. I'm sorry to disappoint you, but I've joined it.
You've joined the wrong meeting on the last minute for the first to be a minute early.
Okay. Oh, I'll record that, and it's available for everybody on YouTube to see.
Very good. Very good.
Brilliant. Thanks.
I'll see you in the next meeting.
Okay. Still in Japan, I hope. Yeah.
No. Yeah, I wish. Very observant. I like it. Okay.
Cool.
Well, we might wind it up there, and like I said, we'll try and get this up on YouTube, which will be a change for me because I'm a bit useless like that. So that other people can look at it. And to your point, Eileen, yeah, we'll look to move to the eHealth forum as soon as I hear back from our good friend Nathan, who was going to do the move for us, so that people will only have one login. So that was all about user experience. So, at the moment you have to have a login to Yammer, and you would have to have a login to the eHealth forum, and we're like, just have one login where everyone wins. So there you go. Okay, well, thanks a lot. I'm going to be away in 2 weeks' time, so I might leave this meeting in the good hands of Eileen and Mary to continue on, and I'll see you when I'm back from my holiday. My holiday is in Japan, but it's somewhere that likes beer, dark-coloured beer, so you might be able to guess where that is.
And rains a lot.
Yeah, and rains a lot. That's where Eileen's from. Anyway.
I am lovely.
See ya. See you soon. Bye-bye.
See ya.
Thanks. See ya.
Get it.